University of Kentucky. I did a super fellowship in atrial fibrillation. So can you all hear me? Yes. Yeah. And so a lot of my practice now, part of that is creating a program for atrial fibrillation. So this kind of is close to my heart. Unfortunately, I have no financial disclosures. So this topic, we're going to be just briefly going over the definition of atrial fibrillation and all the minutiae thereof. We're going to talk about the background and how it affects us and as a population. We're going to discuss the team approach to atrial fibrillation as well as the treatment options. We're going to discuss the outcomes and then overall conclusions of where we currently are in treatment modalities. And so some of this is probably review. So atrial fibrillation isn't just one entity, it's sort of a spectrum. There's paroxysmal atrial fibrillation, which develops into persistent atrial fibrillation and long-standing. A lot of that's just the duration of how long you're in atrial fibrillation. And then another definition I thought was important was the ligament of Marshall, which is pretty much the remnant of the embryonic sinus venosum. It's as a vestigial fold, and it's between the left atrial appendage and pretty much the left superior pulmonary vein. And more recently, they found that that's been a very strong epicenter for atrial fibrillation. So it's something that's much more easily managed surgically than with our EP colleagues, and so that's something that we'll be talking about. So as I said, atrial fibrillation is a progressive disease. About 20% of patients will progress from paroxysmal atrial fibrillation to persistent, long-standing atrial fibrillation within that first year of even experiencing atrial fibrillation. So first episode of atrial fibrillation, these are all averages, obviously, but within 4 years, a lot of people are still suffering from permanent atrial fibrillation. And it is, stars. It's a disease that significantly affects our U.S. population. About 8 million people in the U.S. suffer from atrial fibrillation at all times, and approximately half of those people will develop long-standing atrial fibrillation. The question is, why does it matter? Atrial fibrillation is self-perpetuating, it's progressive, as we just said, and it's a systemic disease that it can have very dangerous consequences. There is actually people will have a lower survival rate, shorter lifespan, and a decreased quality of life. Some people will have atrial fibrillation and never experience any symptoms, and some people it is life-limiting and they suffer from it all the time. There's a 5 times greater stroke risk in this population, and about 5 times higher risk of developing heart failure, and about a 50% greater risk of death as compared to patients who do not suffer from atrial fibrillation. This is a great slide. I always think this is interesting, and it's pretty, so these are cancers and survival. And as you can see, patients who have untreated atrial fibrillation in about 5 years, about 50% of the patients are no longer with us. Obviously, this has complications thereof, but that's a pretty striking number as you compare it to other cancers that we are more familiar with. And not only does it affect our patients, but it's also a huge strain on, a huge economic burden on our healthcare system. So on the left of our screen is patients who do not suffer from atrial fibrillation, and these are the annual costs for patients. So about, on average, about almost $12,000, but it increases almost by $10,000 for patients who have atrial fibrillation. That's patients, inpatients, outpatients, and even pharmacologically. So it is a huge burden on the disease, on our population, and it's projected to go up almost double in the year 2035, just given our growing and aging population, from about $37 billion in the U.S. to almost $70 billion, which is a pretty astronomical number. So this slide sort of highlights how patients, how much of a burden atrial fibrillation is on the healthcare system. So 2/3 of people going into the ER have some pathology that is associated with their atrial fibrillation, which is that's more than 500,000 patients coming into the ER annually will be there for some element of atrial fibrillation. And about 500,000 people are contributing to the new hospitalization. So this sort of complements that previous slide. With these staggering numbers, one way we're talking about approaching these is making sure that we have a multidisciplinary approach to atrial fibrillation, a programmatic approach. This isn't just the EP or the electrophysiologist or the cardiac surgeons. It's a combination of not only the electrophysiologists, the cardiac surgeons, but pharmacologically and also the ER physicians, and that's usually what makes the team for an atrial fibrillation program. So any multidisciplinary atrial fibrillation treatment team will use all of these different modalities, and there has been a significant reduction in healthcare resources amongst hospitals who have these developed teams, as well as admission rates and length of stay. And it makes sense if you have a cohesive team, you're looking at it from all different perspectives, but this has become a more programmatic approach to this disease. So we're going to go into treatment options. And the traditional treatment option for atrial fibrillation is the paramount of that is medical management. So rate control, rhythm control, risk factor modification. So patients who have significant obesity tend to have higher risk of developing atrial fibrillation, and then also reduction of stroke risk with atrial fibrillation. So that's like anticoagulation, Coumadin, Eliquis. And try to reduce the risk of congestive heart failure and long-term sequelae of atrial fibrillation. Medication alone is significantly less effective than having any sort of intervention. The traditional approach for this is catheter-based treatments. So the catheter-based treatments are significantly more efficacious than medical modalities alone. It has a significant improvement in quality of life, almost 20% higher than if medications alone. And then as far as the cost, the cumulative costs of actually intervening on these patients is significantly less if you actually intervene, even if you're just doing a catheter-based ablation. And so this is the slide just illustrating the effects and the impact of ablation on healthcare. And you can see the outcomes just to have a significant reduction of risk of ER visits, hospitalization, and even antiarrhythmic drugs once you do get them into a normal sinus rhythm. So ablation, and we will talk about the efficacy of that versus surgical ablation that in the next slide, but there are also, in addition to catheter-based ablation techniques, there are surgical ablation techniques. In the 1980s, I think it was 1987 or so, Dr. Cox created this Cox-Maze procedure. And so essentially what he was doing is he created these antiarrhythmic ablation lines using multimodality techniques. In the modern era, we're using things like cryoablation as well as radiofrequency ablation to create these ablation lines. But originally, he used more of a cut and sew technique, which I'll show you in the next slide. At that time, we would do the resection of that ligament of Marshall, as well as an obliteration of the left atrial appendage, whether you're oversewing, which is another conversation, or you're using an AtriClip to obliterate it completely. It can be used as a standalone procedure or in conjunction with another cardiac surgery. So this image on the right, so obviously that's a heart, and so this is kind of a rendition of the classic Dr. Cox-Maze procedure where it's a cut and sew. So essentially they would go along those ablation lines and they would actually cut and then re-sew it, creating a scar tissue. It has the best, it did have the best numbers of keeping people in normal sinus rhythm, but it did obviously have a very high surgical risk on Dr. Cox's hands. There's a lot of bleeding, and so there was some difficulties with that. But right now, it's a class 1 recommendation in all of our societies, so that's STS, the European Society, the American Heart Association, that if someone has a history of atrial fibrillation and it's appropriate for that patient, that you need to do something. You need to do an ablation somehow because that will improve their overall survival. So this is just, again, illustrating that if you are in there and someone has a history of atrial fibrillation, that you should be doing a concomitant maze procedure or a rendition of that. So the survival, as you can see, it does taper off at the 10-year period, but it's almost a 50% improved survival if you're doing it in addition to whatever cardiac procedure you were initially planning if the patient has a history of atrial fibrillation. Or even a high risk for it, you could probably make an argument that's more stuff that we're doing research on currently. So this is just again saying that you need to do something. There's a lot of different types of operations you can do for atrial fibrillation. It's not just a Cox maze. A Cox maze traditionally is going along all of those ablation lines, and the more arrhythmogenic lesion sets you do, the better the efficacy of the treatment is. So on the left side, PVI catheter outcomes, you can see that one of the big downsides for catheter ablations is it usually takes more than one to get to that point of maximal efficacy, which is about 70%. And so the question is, how many ablations is too many ablations? Because there's always a risk with whatever we do, as we know. You can see the efficacy of any sort of surgical ablation, so bilateral pulmonary vein isolation. The box set lesion is just where you're connecting the superior inferior pulmonary vein, so you connect that whole box lesion set. Left atrial lesion, that's where you take the left atrial appendage and you actually go down and create that line, connect the lesion set between the tip of the atrial appendage to the superior pulmonary veins, as well as clipping the atrial appendage. And then a biatrial lesion set, so that's the traditional maze. So that's not only just doing left-sided lesion sets, but also right-sided lesion sets. But I won't go into all that. So that's the traditional surgical approach. There's a lot of different surgical approaches that you can do. As I showed, the more you do, the better it is, honestly, if the patient can tolerate doing those lesion sets. But as everything in surgery is becoming more minimally invasive, so is cardiac surgery. And so some patients can't tolerate a sternotomy for whatever reason that may be. There's a lot of different reasons that patients don't want to have a sternotomy. And so a hybrid surgical approach is something that we are doing a lot more of. Hybrid approach just means that we're working in conjunction with not only, so the cardiac surgeons are working very closely with the EP, the electrophysiologist. And so what you're doing is you're almost leaving certain lesion sets for them to look at in this later and have that quality control. Minimally invasive anti-arrhythmia surgery, so it's not robotic, but it is still minimally invasive if you consider sternotomy invasive, which is another point of contention. So it's a subxiphoid approach to get to that left atrium, and you can get a really nice ablation that is that would take our EP colleagues 6, 7, 8 hours to get that much of an ablation with their point. And this is an Episense from AsiaCure, and you can do, as you can see, you can do overlapping lesion sets. You see it right away. You can test those lesion sets. The hybrid approach differs depending on which institution is doing it. Most people will do a subxiphoid approach, which is also called a convergent, and then do the pulmonary veins. Some people will do bilateral pulmonary veins. There are higher risks, obviously, on the right side than the left side. And then most people will take the ligament of Marshall down and take the atrial appendage as well. So another thing that I love about the hybrid surgical approach is that you get mapping depending on what your relationship and how you protocolized it. This is our protocol at the University of Kentucky. We're probably a little bit more, we just have broadened out our inclusion criteria a little bit, otherwise we wouldn't be getting very many patients. So all of our patients have persistent, long-standing, persistent, or recurrent atrial fibrillation. Persistent, long-standing, persistent atrial fibrillation have are the least efficacious doing it from a catheter-based ablation. So if you have paroxysmal AFib, a lot of those patients are very easily treated with medical management and ablation. But when you get to persistent, long-standing, you have a very large atrium, the efficacy significantly goes down for catheter ablation. So these patients just are, at this point, they tend to be just followed, and you can just see the natural progression of the disease. So this gives us a really nice option. Our criteria is left atrium being about less than 8 centimeters. I know I'm not talking only to cardiac surgeons, but 8 centimeters is huge. A severely dilated left atrium is about greater than about 6 centimeters for both men and women. So that's a pretty dilated. Normal for a man is about 4.1 centimeters. Normal for a woman is about 3.9 centimeters or less. So you can see 8 centimeters is pretty large. Anything greater than 10 centimeters, the efficacy, even from a surgical ablation, is very unlikely that you're going to get them out of long-standing persistent atrial fibrillation in the long term.
1 minute.
Oh, okay. So this is the CONVERGE trial. This just shows the efficacy of the hybrid approach. And these are the 12 and 18-month outcomes for convergent procedures. You can see the blue line is where we're talking just endocardial ablations. I'm sorry, the hybrid is the blue lines, and then the kind of brown line is endocardial ablation alone. And just looking at it, you can see it's significantly different, keeping them in a normal sinus rhythm after the surgical ablation. And so in conclusion, AFib has a huge economic and clinical burden. They're an interdisciplinary approach to atrial fibrillation is not only effective, but it will likely become standard of care in the future. There are multiple approaches to atrial fibrillation with their own respective efficacies. And the catheter ablation is significantly more effective than medical management alone, but concomitant surgical ablation is not only effective, but one thing that I didn't show is that it gives you feedback. So a lot of times what I'll do is I'll have my EP doctors do a 30-day mapping afterwards, which I love. I love that kind of feedback because as the swelling of the heart goes down, some of those ablation lines, there'll be skip lesions in those lines, and then they can do point areas of ablation, and so you get a really nice overall outcome. And then hybrid approach to atrial fibrillation is more effective than catheter-based alone. And this took me probably longer than the whole slide set to find the right cartoon.
Okay, we have some time for questions. Are there any? That was a great talk. I really wasn't fully aware of such a high morbidity and mortality from just AFib. So thank you very much for that. I have a couple of questions. One is, what's the recovery from this procedure? And if we're thinking about, say we have somebody who's coming in for another kind of surgery, some general surgery, should we be looking at sending that person as part of their cardiac workup to have a more definitive treatment for their AFib than just the medical management? And then what's the recovery from this procedure? You were talking about this 30-day mapping, and so what kind of a recovery do you need before you say, okay, you're in good shape to go and have your whatever it is, ventral hernia repair or whatever?
Those are great questions. So some of those are all institution dependent, and also the hybrid approach is there's variation in it. So if you have bilateral VATS, so video-assisted thoracoscopic, and doing bilateral pulmonary vein isolation with a subxiphoid approach, you're going to have a little bit longer length of stay. But on average, it's anywhere from 2 to 4 days. So it's pretty similar to having a VATS procedure. You have so oftentimes with my patients, the subxiphoid people tend to, I will leave drains in the subxiphoid as well as the left pleural space. Usually I'm able to get them out the next day, and then just depending on their pain tolerance, because a lot of my patients tend to be a little bit older and a little bit more frail. And so sometimes I'll keep them just for pain management, because anytime you do a VATS procedure, it hurts. As far as preoperatively, so patients with long-standing persistent atrial fibrillation it's a chronic disease. So I wouldn't say it would preclude someone having more of an emergent procedure. And also this type of procedure, when I'm counseling my patients, I make sure that they're very aware that it's very possible that they will be coming out of the hospital in atrial fibrillation. So 1 out of 3 people, just by touching the heart unto itself, it creates swelling, and that will create temporary atrial fibrillation. And so creating those expectations is really good. And so what we will tend to do is we have them come back in 30 days. I'll make sure they're in a normal sinus rhythm. We do a Holter monitor, and then I'll send them back to the EP. and the EP, he will most likely take them off anticoagulation within a 3-month period. That caveat is they're getting an atrial clip. There's no longer an atria, a left atrial appendage. When people are doing amplexers and just plugging in, people feel comfortable taking them off of anticoagulation. So it reduces the risk about 80%.
So is it contraindicated to come off anticoagulation in that 3-month period?
So that's kind of what I was getting at. So the cardiologist will often take patients off of anticoagulation after they put a watchman, right? But with this, there's just not that data. We're actually currently doing a prospective global study where we're looking at prophylactic clipping of the atrial appendage. We're just probably more conservative. Yes, sir.
Great. So, no, thank you for that. I think this is for the benefit of ICS as we get to have this variety of specialties and learn from each other. My question is similar to hers. What's the operative time? You know, you said long ablation can take 6 to 8 hours. How long is your procedure take?
So everyone's different. Like the first few I was doing, so the way that I do it, I'll do a subxiphoid approach, and then I'll put a bump on the left side to expose their left side. So I don't need to move them. If you're doing bilateral approaches, sometimes you will have to switch them. When I first started, I would take maybe 3 hours, maybe sometimes even up to 4 hours, just depending on the patient's body habits and whatnot. I'd say on average it's about 2 hours. That's usually what I book it for.
Thank you, Dr. London Banks. We are going to invite Dr. Michael Jacobs. Thank you. So next, next topic is total laparoscopic Whipple procedure, a video case presentation by Dr. Michael Jacobs. He's a clinical professor of surgery at Michigan State University, director of the HPB program, HPB fellowship, associate chair of surgery at Ascension Providence and Providence Hospitals. Just to add another title, he's one of our previous president of ICS, so welcome back, Dr. Jacobs.
All right, thanks, Siva. I appreciate that. Thank you, everybody, for sticking around so late. So hopefully we'll be able to put on a good show here for you. So I have nothing to disclose as it pertains to this lecture, but I do think laparoscopic and probably more so robotic Whipple is the way to the future, the immediate future, actually. And I'll demonstrate some laparoscopic videos and then put my 2 cents in as to the robotic approach. It took a while to get enough nerve to do a laparoscopic Whipple. To date, I've done over 600 Whipples. It started off with a lot of basic laparoscopic skills that worked their way all the way up until finally culminating in our first one in 2011. And then with that has brought a whole wave of other multidisciplinary types of team approaches and things as I've alluded to here, including an accredited HPB fellowship. We're now on our 10th fellow and only one of 14 in North America. Briefly, we're just going to talk about some of the anatomy, some of the old standards, new standards, and the operative therapies. Our primary regional focus, this is a slide here at Peter Lodge out of Leeds, England. And the area that we're just going to focus on today is the pancreatic head and for the Whipple, which I suspect most people in this audience are familiar. Whether you do it laparoscopic or open, the typical contraindications and indications are if you have any periapicillary mass with obstructive jaundice, you do not need a biopsy to proceed with resection. So if you have a mass that's causing jaundice, double duct sign, that requires an operation. You have to decide if the patient's operable. If not, make them operable. If the tumor's operable, take them to surgery. If it's not operable, give them neoadjuvant chemotherapy and try to make them operable. Occasionally we'll do metastatic disease. A classic indication would be a renal cell carcinoma. Occasionally we'll see isolated breast metastases or a melanoma to that area. But still the standards, for the most part, and this is changing, our lung, liver, peritoneal metastases are still overall a contraindication to resection, at least in the absence of a clinical trial. Celiac adenopathy, if it's positive disease, would render them stage 4. aortal cable disease, stage 4, and we don't typically do extended lymphadenectomies for these patients, as was once previously studied. If the SMV portal vein is thrombosed, as a general rule of thumb, that's still considered a contraindication. There are people resecting, and it's not a technical issue, it's just trying not to disrupt the collaterals of the vessels around it so that you don't render the patient's bowel with venous stasis. And then remember for the SMA, watch out for the uncinate process. And this slide here that I'm going to show next shows just that. This is a SMV, this is years ago, took a patient to the operating room, and this is the neck of the pancreas slung, the tumors in the pancreatic head, and this is all tumor burden. Now that patient will get neoadjuvant chemotherapy and be considered initially borderline resectable and then be considered for surgical therapy. We still resected that patient with a vein resection, but again, they have advanced disease, so their morbidity and mortality will be much higher. The usual contraindications to laparoscopic approaches apply to the hostile abdomen, inability to tolerate CO2 inflation, huge ginormous tumors, such as what's described there. That was a giant GIST tumor coming out of the second portion of the duodenum that required a Whipple, and that would be technically difficult laparoscopically, obviously. Again, just a slide to get us on track. And this slide here is more or less what you would typically see on an open resection. Still about 98% of the world is still doing open surgery, standard of care, gold standard. Should include a regional lymphadenectomy, ideally shoot for a minimum of 15 lymph nodes. This represents the neck of the pancreas divided with chronic pancreatitis, 1 centimeter duct, splenic vein, portal vein, SMV, middle colic vessel, inferior pancreaticoduodenal vein, and you barely see it here, superior pancreaticoduodenal vein, bulldog on the bile duct, and the duodenum has been resected. The junus can be brought up through that loop. When I do it laparoscopically, this changes a lot based on body habitus, but as a general rule of thumb, these are my trocar sites. I have now gotten it down to 4 trocars with an infraumbilical, and basically 2 on the right and 1 on the left. Somewhat similar to a laparoscopic cholecystectomy, just pushed out a little bit further. And so this next slide really is more representative of what I would typically have set up, with the exception I haven't placed my 4th trocar yet, which will go towards the top side of the drape there, so that you have a right-handed suture with, and then we transfer the camera to the mid-clavicular port, as you can see there, and do the procedure. So this should highlight. If you can't see it, we can dim the lights. And this does not have sound, so I'll try to talk you through it. And let me get to the pointer. So, see, you guys have a pointer? Doesn't work? Okay. All right, so let's see if I can get the pointer on here. Do you have a pointer that works?
Yeah, right in the lights.
Can you dim the lights for me?
I don't know how to do that.
Or just turn them off? So just real quick, we've already, this is sped up. This is a 5.5 hour surgery condensed into 12 minutes. So the stomach is up here. We're tenting up the distal antrum of the stomach, and we're already at the level of the gastroepiploics down here. The GDA will be on the bottom of that. We isolate that. My device of preference is the ligature, Hem-lock clips. We're going to take out the artery and the vein. Try to take it low so that you get good nodal clearance from that area. You can ligature off the top. And we do the same thing to the vein. We're now doing a Coker maneuver, so the cava's on the back here. Very obese patient, BMI of 46, and which actually they do better, and it's actually easier to dissect. So now we're already up at the level of the portohepatis. Cholecystectomy was previously done. We're starting to see glimpses of the bile duct. We're going to start a regional lymphadenectomy, and you can skeletonize this fairly nicely. I generally use a dolphin tip. We didn't have it that day, so I used that, but I think in the next video I show you, we'll be showing it. We start our regional lymphadenectomy. I prefer to divide the GDA with a stapler. You can tie it. I used to do that. You can put Hem-lock clips. You can do that. But the problem with all that is they can start to create staple and clip traffic. So I've just found it easier to just use a stapling cartridge. Now we're along the, starting to dissect more lymph nodes along the bile duct. This is the bile duct here. That'll eventually get transected above the cystic duct at this level, but I save that for last so that you reduce the biliopancreatic, or at least the bilious drainage, so you're not contaminating the area. You can see it's relatively free of that. And so watch out for a replaced right hepatic artery. This patient does not have one, but for the residents in the room, that's where it runs, right along that groove right there. And it comes off the SMA in 20% of people. We've got the GDA lifted up. That's going to come down to the common hepatic. That's the portal vein on the back. We're starting to isolate that tunnel, so you have the bile duct on the left and the artery on the patient's left and the other on the right. So now we're going to start the portal vein tunnel. We've already divided the stomach to make it a little bit easier. You can also do pylorus preserving. My preference is to do a gastrectomy. I've never operated yet on a patient that's had an antrectomy for gastric outlet obstruction. I did a whole bunch of pyloric preserving early in my career, and at least 3 or 4 of them have been operated for gastric outlet obstruction. This is a portal vein SMB tunnel. We're going behind. Hopefully you don't have an anterior vein branch. Occasionally you will. Be careful for that, so we go slow. I loop it with an umbilical tape or an umbo tape, and that allows for nice ginger retraction. We haven't done anything yet significant, so it still could back out if you wanted to, or, you know, but I still do an ultrasound. Why am I doing that? Just to ensure that I'm going to be wide enough past the neck of the tumor. So now we're going to divide the neck of the gland. I'll usually divide the top half of it with electric cautery. This patient's going to have a small duct. Normally by now, if they have a dilated duct, that should be gushing out at this point. Watch for the main pancreatic artery will traverse somewhere in the upper half of the gland. And we just come through that cautiously. And then usually once I identify the duct, which in this case will be somewhere right in there, I'll go through that with cut mode to minimize cautery artifact and damage to the duct. And I'll divide the back wall of it with the ligature. You can see the pancreatic juice dribbling out of the gland. So here's the ligature. I'm just going to divide the back of it once I've divided it, just to help control those arteries. There's usually some bleeding from the inferior and superior portion of those. Be careful along this side wall, especially if there's local invasion. This one doesn't have any of that. There's a periambulary small cancer, T1 tumor. Uncinate process is being tented to the left. This is the SMB on the right of the screen. And we're going to very tediously dissect this out. Robotically, a lot of times, it would be actually easier to take this down first and lift it up. And it frees up your hand to be able to take that almost in like an SMA approach first approach. So underneath that wall is your SMA. And so we're just going to come down that line. This is the duodenum being retracted upward. Still tediously dissecting. Watch out for the first jejunal branch. We'll see some of those a little bit more clearly. And you can see the patient, we're battling the patient's Gerota's fascia, just massive obesity. And so now we're going to identify, I generally still go infracolic to do all my work. Some people will pull the jejunum all the way through the ligament, and that's fine. You can do that. I just prefer to do it this way. We mobilize this as a very tedious step. You can get into some bleeders here. You should have a suture available. And we divided that already. Now I've already pushed the jejunum and duodenum to the right side of the mesentery so you can see that hollow. And now I used a different video to show this, but this is the ligature with the nice fine tip. It works very well for this. And we're going to take down all those branches, being, again, careful not to take out the SMB. Here it was already taken down with all ligature. A lot of times, I think in the next video I'll show I use the stapling cartridge, which is quite handy. We've divided it. This is the bile duct, nice blood supply, just flash cautery in a low setting so you don't traumatize it. And that concludes the resection. The specimen is bagged, brought out usually. The pancreatic neck margin and or bile duct margin can be sent. You can also easily send a bile duct margin from that. It's somewhat tedious. When you do send the margin, obviously you want to send it off a piece you cut off, not back on the gland that's hemostatic. Create a right-sided mesocolon rent. This is the middle colic coming up this way, and you can mobilize your proximal limb through that. Because the patient's so obese, I actually put a stay suture to the top of the peritoneum there. And usually, unlike an open operation, I don't know if anybody's done any lap or robotic Whipples, but typically in an open operation, you'll do the pancreas first, followed by the bile duct, then the stomach. So here, I usually will do it in reverse. It's not mandatory, but I'd rather do the bile duct and start distal and work more proximal with relation to my instruments. You can see the V-lock sutures that are now available. I just run the back wall, and then I'll usually run the top wall with a separate one. A lot of times I'll do interrupted sutures on the top and a running on the back just to save time. And it makes it quite easy. I don't stent the bile duct typically. If I did have to stent the bile duct for a small duct, say 4 millimeters, 5 millimeters or less, then I would probably put a T-tube in the bowel and do it that way. In the bile duct across the bowel and do it that way, but I don't do that usually. This makes for a quick anastomosis. Again, it might look like I'm nervous with my hands shaking in there, but you know, it's actually the trocar play inside the trocar. The robot completely eliminates all of that. So there's no movement at all. It's steady. So you see all this kind of play back and forth, and that does create a lot of visual fatigue and a lot of manual fatigue. We're now going to start our pancreatico-enteric anastomosis. I put, in this case, a 5 French pediatric indwelling feeding tube as a bridging anastomosis. It does not reduce the risk of leak. It helps to reduce the risk of stricture. So we're trying to reduce prolonged postoperative EPI, progression to worsening diabetes from chronic pancreatitis from pancreatic anastomotic stricture. In this case, we're using 5.0 Maxon. You can use 5.0 PDS. Nowadays, we have a non-absorbable Stratafix. When we did the first Whipple in 2011, these would all be done with interrupted 3.0 silks, just like I do my standard ductal mucosal anastomosis. So this anastomosis usually now will take about 45 minutes to an hour, depending on the tedious nature of the duct. It's all about this duct right here. So the back wall, you want to get a good good approximation, leave a nice cuff, 1 centimeter bites. Make your enterotomy, and you'll dunk that across the anastomosis shortly. It takes a really good camera holder. That's the other thing that the robot takes out of the picture. What you're not seeing in this 5.5-hour video is the withdrawing back and forth of the camera because something gets splattered, it gets fogged, and there's probably at least 45 minutes of time wasted with the camera coming in and out on the traditional laparoscopic method. I don't know why that doesn't happen robotically, but it happens substantially less. Don't panic. The blood supply, when I see bleeding, if you tie it, it will stop. Don't cauterize it. Just tie your suture and it'll be fine. And once we get done with our pancreatico-enteric anastomosis, then we'll proceed to the anterior row. And that's, again, that same suture just brought forward, overlapped over the top. And I will usually run it forward and then back again to the bottom wall, and then incorporate the mesentery of the transverse colon into that staple line so it buries it and kind of pushes it down. And then naturally, at the end of this, will be widely drained. The clips are there left intentionally for 2 reasons. One, for bleeding. We're now suturing the mesenteric defect. I leave clips there because I had somebody biopsy the bowel thinking it was a pancreatic head cancer after a Whipple, and they biopsied the bowel and got normal mucosa without consenting me. So now I leave clips there so in hopes that they know, and I tell the patients, remember, don't let them sign you up for a biopsy. This is your gastroenterostomy. This is a anticolic, retrogastric, vertical gastrojejunectomy, and then just close the top layer shut and leave white drains. The next slide that I have to show has audio, so if it comes on, I'll try to turn it off real quick, otherwise I'll talk you through it. So this was presented at the AHPBA in the Master of Surgery section on uncinate process dissection. So I'm going to focus, and this is my last video, I'm going to focus a little bit more on just the uncinate process dissection. So most of all that other stuff has been done. These are my colleagues, former fellow, current partner, previous fellow. So this patient, we're going to demonstrate dissection of the uncinate process. It's probably the most critical step for 2 reasons. That's where you get your most blood loss and risk, and that's where you tend to leave a positive margin. So it's a very critical step in the operation, whether you do an open laparoscopic or robotic. And so in this case, it's another 55-year-old obese patient. She has a dysplastic IPMN. The area that we're going to focus along is along this uncinate process, pancreatic head, and that pancreas tends to extend almost all the way up. So we've already mobilized this area quite well, and this is the uncinate here being flipped over. I've divided the jejunum and I brought it through, and now we're going to retract. This is actually what I have seen done fairly frequently in robotic Whipples, which significantly reduces the operative time, now down to about a 4.5-hour average. I truly believe the robotic Whipple will become, within 5 years, the standard of care for people that can learn how to do it. I don't think people have enough time to learn how to do the laparoscopic technique. It's just too time consuming. This is an inferior pancreaticoduodenal vein. Be very careful of the first jejunal branch, can be very dominant and wrap around this. We're now dividing the neck of the gland, and same exposure on the pancreas, very tedious dissection. Most of these branches that are there are 1, maybe 2 millimeter size branches. If they bleed, just put a sponge on it, and as long as the patient's not coagulopathic, it will stop. And then you can come back and hand sew it with a 5-O-proline or whatever you like. So we're just going to very tediously take this down. And again, we're being very careful. When I'm doing it, what you're not seeing is I'm sort of pushing my right hand against the SMA. You can do a little bit more of an SMA first approach where you flip it back and get the back wall. So now this here is actually a replaced right hepatic artery coming up. This is the superior pancreaticoduodenal artery arising from that. And you can clip it however you want to get at it. So again, two clips usually works. Ligature off the other side. That will usually really devascularize the gland. You'll see some back bleeding from additional branch I wasn't expecting here. And rather than screwing around, I'm just going to fire a stapler across it. And I do that because I can clearly see the trajectory. You'll see the bleeding now. You'll clearly see the trajectory of the SMA coming into the, so I feel very confident I can fire a stapler across that. And I didn't put any clips there because then you create a bunch of clip traffic and then the stapler won't fire through it. So here's the bleeding coming up some point. Nothing torrential, but you can see it. You know, a ligature is not going to control that. So you need to just back out and just fire a stapler. In this case, it's just a vascular load cartridge. And that pretty much completes it. And then you go ahead and you continue. If you have some additional mesopancreas, again, if you can see your plane, you can divide that flush. You can see the top of the SMA here and divide that off. And again, this is a little wobbly just because we sped the video up for time, just in the interest of trying to get all this in. So I do apologize. So I can't stress enough, avoid clips in this area. If you're going to use staplers, put them on after. And number 2 is do not crimp the SMA when you're firing the stapler, especially if the tumor is in close proximity to that back wall. You can very easily crimp it. Okay, so these are typical traditional sites. So using some of the data from Horatio Asman, who's now down in Miami, and John Stouffer, who was up at Miami. They were partners at the time, in Jacksonville at Mayo at the time, but they basically demonstrated a significant improvement in all variables for laparoscopic, non-robotic versus open. It took longer, but they had the same node harvest ratio. Length of stay, hospital stay, ICU stay, and transfusion rate was all statistically significantly less. No difference in complications, most specifically pancreatic fistula rate. Like I said, in our own experience, we published this back in 2013. We found early experience suggests decreased length of stay. Ours was 6.6 days. Our open average is 8.5 days for non-complicated cases. Decreased blood loss is 136 mLs, easy to monitor because you're sucking it out constantly, and they have a much quicker return to recovery. They really post-operatively behave much like a laparoscopic cholecystectomy. So in conclusion, open pancreatectomy, as we all know, has been proven to be safe with a less than 1% mortality rate in the right hands. Laparoscopic, and I'll just put in there robotic, pancreatectomy is also safe, again, in the right hands. And I do truly think this will become the standard of care. Both have complex learning curves, especially for complex robotic cases. I wouldn't recommend just jumping into a robotic Whipple if you have not done and mastered an open Whipple. And obviously multiple variables and factors are involved in that process. And I thank you very much. Thank you.
Thank you. We may have time for one question. Yes, go ahead.
Erika, do you use the somatostatin to decrease the secretion of pancreatic?
Yeah, so the question is, do we use sandostatin or somatostatin to reduce pancreatic leak? The answer is no, not prophylactically. So my postoperative care plan is IV PPI, like pantoprazole, something like that. Reglan on day 2, 5 milligrams, that's metoclopropamide, 5 milligrams orally to stimulate the stomach, and early withdrawal of the nasogastric tube with early ambulation. And typically antibiotics. So depending on if they have cholangitis based on the cultures, either 24 hours or 7 days worth of antibiotics. But the short answer is no, unless they get a clinically significant fistula, meaning the fistula is present and it's impairing bowel function, prolonged antibiotics, prolonged hospitalization, high volume output. Then we will start sandostatin, usually 100 micrograms twice a day, sub-Q. And oftentimes we'll send that home on it if we need to. So the fistula rate in our series is 6%. So fortunately, not a lot of people have that. So, thank you.
Thank you so much, Dr. Jacobs. That was a really beautifully edited video as well. It's a fascinating topic. Next, we're going to hear about pulmonary infarction after Dialysis Catheter Exchange. Dr. Pahilski, clinical professor of surgery at the University of Illinois at Chicago. And also, to add yet another title, past president.
Good afternoon, Harvey Souls. The best of times to give things, the last day on Saturday afternoon. Well, I certainly cannot compete with Dr. Jacobs' technical wizardry in terms of, I always watch his pancreatic presentations, just left shaking my head about how beautifully they go. But anyhow, what I'd like to talk to you today about is something that came across my practice recently that I think we underappreciate the impact of, both in terms of finding it and in terms of what we have to do with it. We've talked a lot on the earlier sessions about transplant, especially renal transplant. And you talked today and yesterday a lot about the transplant itself, but you didn't say much about what gets you to the transplant. And that's a rigorous process to make sure that people don't have malignancy, they don't have underlying cardiac disease, and a lot of those people who are on for transplant will trickle through my office with various and sundry lung findings that we have to go through a whole workup for before they're listed for transplant. So this is potentially one of those folks. I do not have any financial disclosures. If you look at the global burden of chronic kidney disease, it's estimated that about 10% of the population, which is 800 million people, suffer from some type of chronic kidney disease. Most prominent in women, older patients, racial minorities, and patients with uncontrolled hypertension. And this is just kind of a nice little thing they have with the number of people. But most frighteningly is if you look at 2013 to what's estimated to be in 2040, there's an increasing death risk of chronic kidney disease. So it's important that we figure out how to get these folks the treatment they need with dialysis and hopefully kidney transplantation. If you look at the areas that have the highest risk of chronic kidney disease, you can see Mexico, most of Central America, Paraguay, the Middle East, Saudi Arabia, Oman, and the Southeast Asian area. And then if you look at the risk of kidney disease as age increases, there's a linear trend upward for both all stages of kidney disease as well as more advanced stages of kidney disease. And this slide just lists some of the representative areas throughout the world, and the risk of kidney disease and the things that pop out is in Europe, you have a fairly high prevalence of all stages of kidney disease. And then if you zip over to more advanced stage kidney disease, the US is pretty much the highest. So what do we do with chronic kidney disease? Well, usually hemodialysis. So it's estimated that there's over 2 million people worldwide who are on dialysis or have had a kidney transplant. But that's less than 10% of people who need treatment. Hemodialysis is the most common cause of replacement therapy and represents about 89% of all types of dialysis, the other mainly being peritoneal dialysis. What got these people with chronic kidney disease is what gets them with cardiovascular disease as well. About 2/3 of those people have cardiovascular disease as well. And again, the outcomes are very variable depending on where you're at in the world and your financial resources of your healthcare system. And this is just a nice slide that shows expected years of life in the average population and then in the population of people who are on dialysis. So we get into a bit of an ethical dilemma when we start talking about transplanting older patients with lower amounts of expected years of life in terms of our utilization of transplant organs. And here if we look at treated kidney disease by country, you can see Taiwan leads the pack, the United States, Mexico, Japan, and Singapore in terms of incidence. So people who do get hemodialysis, what do they have? Well, a lot of different things: fatigue, reduced quality of life, depression, anxiety, cramps due to various electrolyte disorders, pruritus, sexual dysfunction, poor sleep, just a whole variety of things. So let's go to the patient that rolled into my office. It's a 40-year-old man with a history of obesity, poorly controlled diabetes, poorly controlled hypertension, and cardiomegaly. Long-standing chronic renal insufficiency. You get most of the highlights here: obesity, hypertension, diabetes, and his issue is that he has bilateral retinopathy, so he's legally blind. He has chronic shortness of breath. He wears a BiPAP mask, and mostly he's ambulatory and very limited status and is in a wheelchair. So this fellow was felt to need to go on dialysis in 2021. He had a right IJ permacath placed, which was functioning well for about 2 years. But earlier this year, he was at the dialysis center getting his twice-weekly hemodialysis, and the center called the hospital and the radiology department and said, "We can't draw blood anymore." So our IR service promptly told him to come in, exchanged the dialysis catheter over a wire with fluoroscopic guidance. The patient was discharged to home within a couple hours afterwards and did well. So here's the post-placement film. You see the permacath nicely situated, kind of in the SVC at the level of the right atrium. You can see the cardiomegaly, and you can see the very nicely defined right border of the diaphragm with an otherwise clear lung. So 2 weeks after the patient's catheter was exchanged, he reported increasing shortness of breath to the technicians. They wanted to send him to his PCP. He declined, but then came to the office the following day. The PCP found him hunched over in a wheelchair, could hardly breathe. He had no fever or chills, but did have a cough with a bit of yellow sputum. He had no white count. His hemoglobin was normal, and his BUN and creatinine were where they usually were after dialysis. So his PCP sent him for a chest x-ray, and I don't think I need to point out the findings of that. The catheter is nicely placed, and now this patient has a moderate to large right-sided pleural effusion with no systemic symptoms. So given his effusion, the knee-jerk reaction with anybody in the ED is put him on antibiotics, do the usual cultures. They thought about doing a thoracentesis, but because he had just had a procedure 2 weeks before, they did an echo on him, and he was scheduled for a CT of his chest. And the plan was for a diagnostic thoracoscopy the following day for definitive drainage and to hopefully find an etiology. So here you can see his CT scan, and I looked at that and said, well, he's got an effusion. We could probably tap it, but let's drain it definitively, give him some good positive pressure ventilation, get his lung re-expanded, because he's in pretty tough shape anyway. You can see the dialysis catheter, the effusion, and the lung. And it wasn't until after the operation, in retrospect, I went and looked back at the imaging and said, geez, you know, that lower lung looks a little interesting. There's a wedge-shaped area of ischemia or abnormality in the lower lobe of the lung. And as we're going to see in the intraoperative films, it made perfect sense what that was. So he underwent a right single port VATS with isolated lung ventilation, one incision over the 7th rib, about the size of what you use to put a chest tube in. We got about 2.1 liters of blood-tinged fluid, no pus, and under endoscopic guidance, we made a small nick in the pericardium and got an additional 400 cc's of clear yellow fluid. At the conclusion of the procedure, we put a single chest tube, and you'll see the postoperative chest x-ray after we look at the intraoperative films. So this is what we saw intra-op. Upper portion of the lung, middle lobe looks good. Most of the lower lobe looks good. And then there's this wedge-shaped area of ischemia. It wasn't frank necrosis, but it was definitely ischemia. And I picked it up and looked at it from a couple of different angles. And then we put our chest tube in, and this is his x-ray in the PACU, which looks pretty good. Chest tube's in place, dialysis catheter is still in place. And a couple weeks post-op, still has a little bit of an infiltrate because he didn't really do much with his inset of spirometer. And the plan was for further follow-up to figure out, make sure his effusion didn't recur. So I looked through complications of dialysis catheter, and as you go through the literature, there's just numerous complications. You can put them in the wrong place, they can bleed, they can get infected, so on and so forth. You can also get pulmonary emboli, not only pulmonary blood emboli, but septic emboli. You can get catheter emboli if they come apart. And the Japanese literature shows a pulmonary embolism as well in a patient with paraquat intoxication. And here's a catheter incident, a case report of air embolism after a catheter was removed and there was a fibrin sheet. So I think you can almost see where we're kind of starting to go with this. And here's the whole laundry list of different possible etiologies for pulmonary infarction, both infectious, iatrogenic, post-lung transplant, extrinsic compression from tumors, but very little is really written about emboli and pulmonary infarction in direct relation to a dialysis catheter. In the spirit of true disclosure, this is not the patient's photo from the patient that I did. They changed the dialysis catheter, threw it out, and put a new one in, and didn't tell me there was anything wrong with the one they pulled out. But I think it's not too much of a leap of faith to see that a patient who had had a dialysis catheter in for 2 years because he declined fistula or graft placement, more than likely had some type of fibrin sheet that was on the end of his catheter that when it was pulled, it embolized into his lung. So the plan for his follow-up was to bring him in a couple weeks, which we did. You saw his chest x-ray, and then to do a repeat CT imaging in about 3 months to make sure his effusion didn't come back and make sure that that pulmonary ischemia didn't turn into a pulmonary infarct and a lung abscess, and to encourage the patient to consider creation of an AV graft and then to be evaluated by the transplant service. The patient unfortunately had other ideas and disappeared to follow-up, despite sending him certified letters and whatnot. So what's the benefit of a VATS versus a thoracentesis? It's definitive management. You're not guessing what you're draining, you're actually looking at it. Had this patient gone to IR and short-circuited thoracic surgery, they would have put a catheter in, they would have gotten 1 liters of fluid. The lung probably would have came up pretty well, and nobody would have been any the wiser what was going on in the lower lobe of his lung. But we had the suspicion that there's something going on there, and why that's going to become important, we'll see in the next slide. Single incision, usually the size of a chest tube. It is general anesthesia. That's definitely a downside in some patients. But the diagnosis of the problem, which showed us that there's potentially going to be a pulmonary scar for this patient, will give us clear guidance as to what we need for follow-up. So it's not just a mystery, well, we had an effusion after he had a catheter exchange. We have a pretty good idea why he had that ischemia and effusion. And most importantly, when this patient rolls down the road a couple of years, if he hopefully gets off the dime and decides to go be evaluated for a transplant, there's probably going to be a scar in the lower lobe of his lung that if he would follow up with us, and we would do follow-up imaging, and we would know he's got a pulmonary scar from where he had an area of infarction, then that's in his medical record, and it precludes him then from another 3 to 6 months of workup in terms of getting on the list for a pulmonary or renal transplant. So just to summarize, chronic kidney disease is an extremely common problem with an increasing mortality. And while renal transplantation is the gold standard, dialysis catheters are going to be with us for the foreseeable future. And you have to wonder with these catheter malfunctions and being exchanged, how many episodes of embolic phenomenon occur that just go unnoticed. And then down the road, when the person is finally evaluated for a transplant, you know, they become a mystery, and you do an IR biopsy and there's abnormal cells, but they can't rule out malignancy. And you do another IR biopsy, and then somebody does a VATS and does a wedge resection, and how much delay you have from potentially something that you could have found out about initially. So as a thoracic surgeon, I will advocate for more aggressive use of VATS, especially to help us evaluate etiology of pleural effusion, especially when they're temporally related to some type of iatrogenic procedure, because most practitioners don't like to admit that they ever have a complication or a problem, but if you start with the fact that it's probably your fault and work backwards, you'll probably have your bases covered. So there's my my bibliography, and I'll take any questions if there are any.
Lexington from Lower Texas.
From a vascular surgeon of all people.
So, great presentation. And as you were presenting before, so I'm reviewing in my mind all these difficult and different type of catheter malpositions that I have been challenged with. And what I see normally when you have these patients who have kept the dialysis catheter for such a long time, the catheter ultimately will cause significant scarring of the major vessels in the chest, which will also contribute to poor flow of blood stasis, perhaps the formation of these fibrous sheets, which will aggravate the whole problem. So if that would be the case, in my mind, I would have thought about doing a CTA and treat it as a PE patient, right? I didn't see if maybe that was done or not, or thought about, but perhaps that would be maybe a consideration. And perhaps where I'm trying to go with this is that nowadays, since we have more and better advanced technology to percutaneously go all the way to the pulmonary artery and aspirate all these clots, maybe that would be perhaps an option to remove this in order to, one, make a proper diagnosis, and two, try to see if we can rescue that lung tissue by reperfusion. I don't know if that was something that was.
Yeah, we hadn't really considered that. It was so subacute. You know, he didn't have the catheter exchange and then have a hemodynamic collapse in the IR suite, which would have then, I think, alerted somebody to do a CTA looking for a pulmonary embolism. And he came in, and you know, I of course am involved at the 11th hour, so the CT scan was already ordered. He's on dialysis. Why they didn't do it just a CTA with contrast, I don't know. The plan, as I mentioned, was we knew what he had. He wasn't septic. He was less symptomatic after we drained the fluid out, so I don't know that he had respiratory compromise from the area of lung that was affected. But I sure would like to know what became of that area of infarction. You know, did it just kind of scar up? Did it cavitate? What happened to it? and a CTA is what we would have planned to order as a follow-up to see if there was any abnormality feeding into that.
Excellent. Great case. Thanks.
That was a wonderful presentation. I hadn't really thought about those type of complications for the dialysis catheters. The images that you showed, it definitely looked like that area was a very focal ischemic section. Did you consider doing a wedge resection for that, or do you feel like it could create a nidus of infection, especially immunocompromised patients?
It looked viable enough that I was willing to leave it, to take the chance to leave it in retrospect, because the guy came for one x-ray afterwards and then disappeared. I mean, we know where he's at. We keep sending him certified letters. He said, leave me alone, I'm fine. I had considered a wedge resection, but you know that boggy tissue, when it's ischemic, wedge resections in the lung, they seem easy until you really start stapling deep into the parenchyma of the lower lobe, and then they get really ugly. And we had drained it. It looked viable enough. I had no white count or anything else, so it was a judgment call not to wedge the thing out.
Thank you, Dr. Popinski.
Okay.
Great presentation. Thank you. Now we go to a future leader, Troy Hollingsworth, third-year medical student from Sioux Falls. Fourth year, I'm sorry, a week ago, so we don't want to recognize that. Single site retrospective chart review of renal transplant graft failure and mortality rates pre and post COVID-19 pandemic. Thank you.
Thank you for that introduction, and I want to thank the College of Surgeons for the opportunity to present here this afternoon. And for a medical student to be part of research and chart review and the design of the study, and then to be able to present it here is a big deal. So I really appreciate that. And also thank you to Dr. Tampi and Dr. Blumenfeld for their mentorship and leadership through this project. We have no disclosures for this presentation. And so a bit about our transplant program. It's in South Dakota, where Mount Rushmore is, and it was established in 2007. And since that time, we've done 265 renal transplants. One thing really interesting about our population in South Dakota is that 15% of our renal transplants have been Native American patients. And you can compare that to the national rate of 1.7% of renal transplants in the United States. Also, we have a single fellowship-trained transplant surgeon at our institution. A bit of background for the purpose of this study is from this AJT article in December 2020, and they just asked the question, is COVID-19 infections more severe in kidney transplant recipients? And basically from this study, they found that the comorbidities of a renal transplant patient seem to have a bigger impact on their mortality and outcomes than their transplant status. And that's kind of off of the question of them being immunosuppressed chronically. How does that affect their response to the COVID-19 infection? And then another study that I want to reference is this AJT article from April of 21, and it was a systematic review and meta-analysis of COVID-19 in kidney transplant patients. And what they really found here is the mortality risk of patients after a year and a half into the pandemic. And it's kind of a number for us to compare to. And then also in their discussion in this paper, they really called even small programs to report their outcomes because they just needed more numbers to get a better assessment of how these patients are doing. And so we're contributing to their call for more publications. And so we did a retrospective chart review of patients that are in active follow-up from March of 2020 to 2022. And we excluded patients that were under the age of 18 and those who were transplanted before 2011 when Dr. Tampi came to the program. So our hypothesis and primary endpoint was that COVID-19 infection would increase rates of graft failure and mortality in kidney transplant patients. And we were also interested in how we were doing in terms of immunization status for our COVID positive patients as kind of a sub-analysis for this study. So here's an overview of our results. And so we started off with 254 patients that met our initial criteria, and then we excluded 79 patients for a variety of reasons, one being that they were transplanted before 2011, experienced graft failure before 2020, March of 2020, and then had graft failure and or mortality before March of 2020. So that left us with 175 patients in the study, and we separated them based on whether or not they had a COVID-19 positive test. So these 93 patients that did not have a COVID positive test, they may have been asymptomatic, never got tested, and so that's why they're in that group. They maybe had asymptomatic course of the COVID diagnosis. And then we had 82 patients who did have a confirmed COVID positive test. And as you can see in this overview, we have 11 total graft failures and then 22 all-cause mortality. And so this is due to COVID-19 or other causes during the time of the study. So looking at graft failure specifically and comparing those rates between these two groups, we looked at the 8 in the no COVID positive and the 3 in the COVID positive group. We did not find a significant difference between these two populations, albeit there were small numbers in both of these populations. When we looked at mortality between these two groups, we did find a significant difference and increase in mortality in those who had COVID-19, which was no surprise to us. And then looking into our patients who did have COVID, we want to know a couple things about them. One of them, were they vaccinated or not at their time of diagnosis? And one thing to note is that some of these patients had COVID before there was an immunization or a vaccine available. But breaking this down, about 60% of our patients who had COVID were vaccinated, and that's at least 1 dose of the vaccine. 2 of our 3 graft failures were vaccinated, and then about half of our mortalities were vaccinated patients. We also looked into the number hospitalized for COVID-19, and about 1/3 of those patients who had COVID ended up being hospitalized for COVID. All of our graft failure patients were hospitalized, and 10 of our mortalities were specifically hospitalized for COVID-19. And so we'll look into those specific patients now. So of those 15, 10 of them, like I said, were due to COVID, but then these other causes of mortality were likely associated with having that initial COVID-19 diagnosis, so they're included here. So in conclusion, based on those results, COVID-19 did not increase rates of graft failure in our patient population, but it did increase rates of mortality in kidney transplant recipients. Our study had an 18% mortality risk, which is comparable to that Kramer meta-analysis I referenced earlier at 23%. And so we're doing well in comparison to that larger study. And one more point I want to make on here, that Kramer article that encouraged to continue reporting even early in a pandemic was important for me as a medical student just to see how I could contribute to the field. So a couple of discussion points I want to share. The first one is kind of a hot topic in transplant, is whether or not the COVID-19 immunization should be a waitlist requirement, and that's for all solid organ transplants. And so this article was a nice discussion on really recommending to make it a requirement for those patients to be on the wait list. Now this is for all solid organ transplants, and so they would include obviously the lung transplants. And they really compared, as an analogy, those patients who would be on the list for lung transplant that couldn't smoke and that their caregiver at home could not smoke as well. And so that's how they rationalize that it should be a requirement for the wait list. In South Dakota, we do not require it, but strongly recommend the COVID-19 immunization. Another discussion point, the immunization rates of our patients compared to South Dakota were interesting. So for all of South Dakota, at least 1 dose was 77%, and then for our all transplant patients was pretty high in comparison at 82%. And then for all of our transplant patients that had COVID, it was about 60% of those had at least one vaccine. So there were some limitations to the study. We have a relatively small volume transplant center and small study sample. This is a retrospective analysis, which has limitations in and of itself. We will likely miss patients who had COVID but were not tested because they're asymptomatic, and the immunization status was largely self-reported because of community vaccination efforts. I want to acknowledge the College of Surgeons for the opportunity to present here our transplant program at Sanford USD Medical Center. Jenna, our PA, who did a lot of organizing for this study and chart review. David, our statistician, my medical school for the travel scholarship, and the rest of the transplant team. I'll take any questions.
Very interesting talk. Thank you for coming. You mentioned about the vaccines for the patients and as well as testing for your transplant patients. Are all your transplant patients required to have COVID testing, whether symptomatic or asymptomatic?
No.
Even,
So
even
that's,
during the heart of the pandemic, they didn't require that?
to my knowledge, we did not require that. The COVID positive tests that we have for the study were only those who were symptomatic because they came in symptomatic or maybe had some procedure done. But there's always an indication for that test.
Two questions. Now, could you go back to your mortality slide?
This one? Or the comparison?
So somebody died of non-small cell lung cancer?
Yes. That's,
I guess they had their transplant before they had non-small cell lung cancer?
yeah. Yep.
And number two, in terms of the immunization, that's a hot political topic, which we won't stray into that. But what's just the general institutional requirement for what do you have to have? Do you have to be immunized for hepatitis B? What requirements does the institution set as to make it a uniform? Okay, you just have to have these immunizations in order to be listed for transplant. Do you know that?
So I can only speak to the COVID vaccine and that we recommend it but don't require it in South Dakota, but I couldn't answer in terms of the other requirements.
What's required? Is anything required?
Maybe I can answer that question. Yes, all the pediatric immunizations, MMR and MD.
Because I think sometimes to depoliticize the whole COVID thing, if you have a level playing field that you have to qualify to be on the list, you have to have your MMR and all your pediatric vaccinations. Well, then it's a required vaccination. The problem is it all gets so twisted politically that people are going to get their heels in and not get vaccinated. But it's just a simple requirement that you tell people, well, you have to be vaccinated for measles, mumps, and rubella, so you should be vaccinated for COVID, and then that should hopefully stifle some of the pushback you may get from some people.
Thank you.
Jacobs, you did a great job. So good job. I had a question. Maybe I missed it, but were you able to individualize what vaccines were actually given to the patients, and was there a difference in terms of Pfizer versus Moderna? Because we know some of them carry a slightly increased risk of thromboembolism, and I'm just curious if you saw that in your population.
So the data that we collected, just to simplify the study, because there are already, I think, a lot of limitations to what we're doing, we just said, did they have at least one dose at the time of their positive test?
I'd be really curious to see if there is a difference. I don't know if it's too much work to go back and pull that data, but it might be, it shed some light. Maybe it would limit or make you more aware of that patient population that's at even a higher risk.
That would be interesting. I agree with you.
Thank you, Lee Trobetta from La Crosse, Wisconsin. So you've established that the cause of the mortality is probably not graft failure.
Correct.
So it's probably, I would extrapolate wildly and say it's probably secondary to immunosuppression, potentially. Do you see a similar increase in mortality in other respiratory infections in kidney transplant patients like influenza or RSV or those other infections?
I probably wouldn't be able to confidently answer that, but maybe I could defer to one of my supporting colleagues.
We didn't look at that population in our study, but that'd be an interesting other future incursion to look into, in addition to looking at the type of vaccine that they got.
And then one more follow-up question. In the context of COVID, do you feel that this has identified a window to intervene? For example, if a patient who had a renal transplant comes to the emergency room and tests positive for COVID, does that lower your admission threshold? Is that a window to intervene to potentially rescue some of these patients who we know are higher risk?
Yeah, I would think so. We did collect if they got treatment for COVID and then what that treatment was. I didn't present all that. I might have some of it up. Yeah, I don't think I have any of that here, but we did look into that. I think from what we got from our statistician, there wasn't a whole lot of interesting differences in the patients, but I think a lot of them got the plasma and like some of the biologics too.
I think in 2023, the leading cause of graft failure is patients that most renal transplant patients die of congenital kidney. And the leading cause of their death is still a coronary cardiac.
Great job. You mentioned something pretty interesting. That was the population of South Dakota is 15% recommended or something. Did you see an increase in the mortality rate of these patients that came in your study? That was either skewed towards or less of that indigenous Native American population as compared to what the rest of the world or the United States is experiencing?
So we didn't specifically delineate those patient populations, but I think that would be interesting to look at. There's a lot of patients, we have a lot of reservations in South Dakota, and sometimes their access to healthcare immediately isn't as feasible for them. So that would be interesting to look at.
That's a great question. In fact, we look at the Native Americans' outcomes compared to the non-Native Americans, and they are in fact quite comparable. So we didn't do it at COVID time, but it was driving the COVID time.
I just think this talk is fascinating. I'm sorry, I'm coming back to it. You mentioned, I'll ask you. You mentioned that a lot of the patients who have mortality after kidney catheter transplant are from MIs, and then you could see that there wasn't a statistically significant difference in graft failure. But when you're getting graft failure, is that from being in a prothrombotic state? I mean, I thought that that's where we were going to go with it. I thought it was very interesting to see the numbers and to see if people who had COVID, patients who were suffering from COVID, were going to have more graft failures if that was secondary to being in a prothrombotic state. Now, I mean, I know the numbers are not statistically significant, but was that part of your theories initially? And kind of follow-up question to that, if most patients who are dying after transplants are caused by an MI from a presumed prothrombotic state, did you notice that the mortalities of the non-COVID patients were matching up with the number of MIs that were the fatal MIs were similar in those patients, or were patients who had COVID more frequently noticing having heart attacks?
So comparing renal transplant recipients who got COVID to those who did not, or non-renal transplant patients. I think
so within these two populations, so the first question was the graft failures. Is that graft failure secondary to being in a prothrombotic state? What is the cause of those graft failures? Do you know?
I couldn't directly answer that question.
I just think it's fascinating. I keep it, because from a cardiac standpoint, we tend to wait. We were just waiting, presuming that patients were in a prothrombotic state for about, an inflammatory state for about 2 to 3 months. So if anybody could wait to have a cabbage for a couple, 3 months, we would do that because we would notice that they would have less thrombotic events. And I was just wondering if you guys were noticing this in immunocompromised patients.
we didn't see an increase rate of renal arterial renal thrombosis in these patients. You know, they were more septic globally. You know, I think you have a slide on the course of that of the patients on the slides. It is true there's some distribution of thrombotic, but this is a high flow environment, so they just less than high thrombotic rate. The big thing that comes to us, is primary prevention. Address the glycemic control, hypertension, hyperlipidemia, basic stuff. So that's the list.
Well, Troy, it looks like your presentation, which was excellent, has generated more questions. So I would recommend that they keep you for your residency in South Dakota because you're a gem and you can continue this very interesting work. Thank you so much.
Thank you.
And last but not least, we have your Levy from Levy's not here for novel technique for wound closure using expanding systems. Okay, well then, we brought the end. I guess this is the end of the session. Thank you all.
So the evening events will start at 7 o'clock at the Stetson lobby.
Yeah.
Yeah, well, thank you.
Because all these guys there.
Yes,
I just thought that everybody brought it out. Yeah.